Hello, I'm John Doobie. Welcome to the Building Mental Wellness learning module entitled Abnormal Developmental Screening, Successfully Linking Families to Services. I have no financial disclosures and do not intend to discuss any unapproved or investigative use of a commercial product or device in my presentation. By the end of this session, you should be able to consider the role that culture and language have on families' perspectives of development. You should be able to identify culturally sensitive strategies to support families who do not seek treatment in a timely fashion. And you should be able to devise solutions to help families navigate the process from the pediatrician's office to community agencies. We'll use a number of case studies to demonstrate these objectives, and I hope that you'll find them to be of special interest. Recommendations for early identification and referral for children with developmental concerns is based upon a large body of literature that demonstrates that early intervention can improve outcomes. This slide shows data from the Infant Health and Development Program that shows significant improvement in IQ scores, as well as mathematics scores, and a significant reduction in likelihood for teen arrests in children who were enrolled in an early intervention program for those with low birth weight and prematurity. So let's take a brief look back just to remind ourselves about the current recommendations for developmental surveillance and screening in pediatric practice. In 2006, the AAP published the policy statement entitled Identifying Infants and Young Children with Developmental Disorders in the Medical Home, and this included an algorithm for developmental surveillance and screening. That report, which is currently under revision but continues to be the active report for us to follow, recommends standardized developmental screening tests on all infants and children at their 9, 18, and 24 or 30-month well-child visits. Here's a graphic depiction of that algorithm. I'd like to highlight number 7, which recommends that we make referrals for developmental and medical evaluations and simultaneously make referrals for early developmental interventions or early childhood services when we identify a child who has an abnormal developmental screen. We're really going to focus on that subset of children today, that is, children who have an abnormal developmental screen, and then what the next steps should be in order to link those children and their families with services. In addition, you'll recall that in 2007, the Academy published recommendations for identification and evaluation of children with autism spectrum disorders. That report outlines a risk assessment or surveillance process for the possibility of autism spectrum disorder. The risk increases if the child has a sibling with an autism spectrum disorder, if there's a parental concern for autism, if there's another caregiver who has a concern, or if you yourself, the pediatrician, has a concern about the possibility of an autism spectrum disorder. In addition, recommendations are made for a specific screening tool for autism spectrum disorder to be administered at 18 and 24 months. The Academy of Pediatrics periodically updates recommendations for preventive pediatric health care. In 2008, a 30-month visit was added to the periodicity schedule. This was added as primarily a developmental checkpoint. It was felt that going from 24 to 36 months was simply too long of a period of time to go without seeing a child to update their overall progress, in particular in the areas of development and behavior. It expanded the developmental and behavioral assessment to include the recommendations that we've just outlined. That is, that developmental screening be performed at 9, 18, and 30 months, and that autism screening be performed at 18 and 24 months. It suggested that developmental surveillance be performed at every well visit, and that psychosocial and behavioral assessments be performed on an ongoing basis as well. We aren't going to focus on the additional recommendation of alcohol and drug use assessment beginning at 11 years of age. However, there's another BMW learning module that addresses this issue if you'd like to learn more. It's important for us to remember that social determinants of health may actually be interfering more with the ability to follow through on recommendations for developmental evaluation or early intervention than medical factors might. Recently, the Academy has made recommendations for us to screen for problems with income and food insecurity. Examples of evidence-based questions that we might include in our developmental surveillance would include, do you have difficulty making ends meet at the end of the month? Or has your family moved frequently in the past year or lived with another family for financial reasons? This screens for housing instability. And then finally, 2 evidence-based questions to address the potential for food insecurity. Within the past 12 months, did you worry whether your food would run out before you got money to buy more? Within the past 12 months, were there times when the food you bought just didn't seem to last when you didn't have enough money to get more? So you can see that the recommendations for surveillance and screening have evolved over the last decade. And yet the question becomes, are we truly making a difference? Are we implementing those recommendations? And if we are implementing those recommendations, are they having an impact on children's overall development and access to services? Guevara and colleagues published this study of pediatrics in 2013. They performed a randomized controlled trial in 4 urban pediatric practices looking at the effectiveness of developmental screening. They screened 2,100 children that were under the age of 30 months and divided them into 3 groups. A group that had developmental screening done with the assistance of someone in the office, a group that had screening without office assistance, and a group that had simple surveillance with age-appropriate milestones. You can see here that the rates of failed screening, or the rates of children being identified with a developmental concern in the context of a pediatric visit, was almost or even greater than twice as high in those who had a formal developmental screening tool administered compared to those who had only surveillance. The rates of referral to early intervention were also significantly higher. However, you can also see that the rates of actually completing the referral were only about 50% of those who were referred. But of those who did complete their referrals, the majority were found to be eligible for early intervention services. The use of a standardized screening tool led to shorter times for identification, shorter times for early intervention referral, and less time before an evaluation was completed. Overall, about 21% of children were identified as having a developmental delay. In another study, King found that about 14% of children failed the developmental screening in the course of a quality improvement learning collaborative, and that about 61% of those who failed screens were actually referred on for further evaluation. Why aren't we referring 100% of the children who failed a developmental screen? This study from Academic Pediatrics in 2014 provides some additional insight. 2,000 children under 30 months of age in 4 urban primary care settings were screened. 21% had a delay found on screening. 58% with a delay were referred to early intervention, and 30% with a delay received an evaluation by early intervention. It appeared that children were much more likely to have a referral and have a completed evaluation if there were delays in 2 or more domains of development, and if there was a fax referral from the office. So if a practice relied on the family to initiate the referral to early intervention, the likelihood that it would be completed was much lower. No referral was often made because the family refused to have the referral, or that the pediatrician felt that the parent didn't really understand the screening tool completely and questioned its accuracy. Let's take a look at the first of 3 cases that we'll review today. The first is that of an 18-month-old who presents for a preventive care visit. In preparation for the visit, the Ages and Stages Questionnaire 3rd edition was administered and completed by the parent. This is the 18-month version. As we review it, we can see that there are no concerns in areas of communication, fine motor, problem solving, or personal social development, but there are definite concerns in the areas of gross motor development. When looking at the more open-ended questions, there were no concerns about hearing, no concerns about expressive or receptive language, but definitely concerns about gross motor development. There's no family history of hearing impairment. There were no concerns about vision and no other concerns about medical problems or behavior. Because this was an 18-month visit, the MCHAT-R was also administered. You can see the responses here. The first half of the questionnaire does not demonstrate any concerns about the possibility of an autism spectrum disorder. This is also true in the second half of the questionnaire. The total score on the MCHAT-R was 0, which gives no concern for autism. Remember that the scoring system is such that a score of 0 to 2 is a negative screen. A score of 3 to 7 requires administration of the MCHAT follow-up interview, and a score of 8 or higher requires referral for further evaluation. You have the results of the ASQ and the MCHAT-R available as you enter the exam room. As a reminder, the ASQ raises concerns about gross motor development. The MCHAT-R is negative for any concerns about an autism spectrum disorder. You observe the child as you enter the room and during the course of the visit, and you obtain the history. The child crawls and pulls to stand and cruises. He can walk 8 to 10 feet holding a finger in each hand and scoots on his bottom as a primary mode of mobility. There is no regression in his development. He's not had any history that would raise concerns about seizures. No other health concerns are raised. He was born after an uncomplicated pregnancy, labor, and delivery at term. There were no medical problems. There's no family history of neurological or neuromuscular disorders. His parents are both college graduates, and there are no social stressors that would have an adverse impact on his growth and development. You review his newborn screen, which was normal. His newborn hearing screen was also normal. His growth and general exam are normal. There are no lesions over the spine. He has normal anal sphincter tone, and he has a good urine stream. His neurologic exam shows that cranial nerves are functional. His muscle tone and strength are normal. His deep tendon reflexes are 2 plus and equal bilaterally. There are no abnormally persistent primitive reflexes, and he pulls to stand, cruises, transitions up and down, but does not walk. Let's take a look at another algorithm that was published in Pediatrics in June 2013. This guides us as far as the assessment of a child who has neuromotor delay. I've blown up the right-hand portion of it to highlight for us the fact that in our particular case, we have concerns about the child's gross motor development. He's 18 months old, and his gross motor skills are at a 9 to 12 month level. The ASQ documents those concerns. These are reinforced by our own observations and our physical examination. So in line 7, the history and exam results are concerning. So we move up to number 8, and the question is asked as to whether the child has high, normal, or low tone. If the child had high tone, and that would raise concerns about an upper motor neuron lesion, then we would consider neuroimaging along with referral to early intervention, which is in box number 10. If the muscle tone is normal or low, which is true in our case, then the recommendation is to measure the creatine kinase and TSH. In this case, the creatine kinase and TSH were both normal. With that in mind, a referral for early intervention or physical therapy would be indicated. There really wouldn't be any need for referral to a pediatric subspecialist in this case, at least not at this time. Giving the child a chance to respond to intervention services, knowing that they have normal tone and normal creatine kinase and normal TSH should allow you to be able to track this child's progress closely and to expect that the gross motor development will improve with intervention. Most likely you'd like to see this child back at 21 months to update the progress, make sure that there hasn't been a plateau in development, and that the exam has not changed. There's evidence to suggest that one of the barriers to having a successful referral to early intervention is that the parents are not fully informed about what will happen once that referral is made. So this slide gives us a picture of what should be expected once a referral is made. You may administer a screening tool as we did in this particular case, and as we saw with our 18-month-old, the screening results demonstrated risk. We pursued our medical evaluation while at the same time making a referral to early intervention. We could ask the family to self-refer, but as we talked about earlier, the success rate is significantly higher if you yourself make the referral. So I'd encourage you to set up a system within your practice to make referrals and to have the parent sign consent to exchange information between yourself and the early intervention team in a two-way direction so that you can get the results of their evaluation. From the date of referral to the time that an individual family service plan is signed, the federal law requires 45 days until completion. So once the referral is made, an early intervention service coordinator is assigned within 48 hours. They must contact the family and provide feedback to you if you made the referral. The service coordinator will make a home visit. They would often contact your office for additional information like immunizations or other healthcare information. So if you can send that along with your referral and send the results of your screening with the referral, it will expedite the process and move things along even quicker. In Ohio, if a child is referred by a physician to early intervention, then they're automatically determined to be eligible for an evaluation that will establish whether or not they're going to be a candidate for Part C or early intervention service provision. And again, with the parent's consent, that report can be shared with you. The results of the evaluation and the parent's guidance drives the formation of the individualized service plan, and that too can be shared with you with parents' consent. The early intervention team then has 30 days from the time the IFSP is developed until the time that services can begin. And again, with parent consent, updates and progress reports can be shared with you. Let's take a look at what the developmental evaluation for our 18-month-old patient might look like. This is a graphic depiction of the results of the Bayley scales of infant and toddler development. I'd like to suggest to you that it's just as important for you to be able to interpret the results of this developmental evaluation as it is for you to be able to interpret the results of a CBC or electrolytes on one of your patients. So let's just review how we might interpret this information. You can see that there's 3 columns here. One outlines which domain of development has been assessed. The middle column gives us a standard score. A standard score would be similar to what we might traditionally think of as an IQ score. The mean is 100 and the standard deviation is 15. In Ohio, a child needs to have a delay of at least 1.5 standard deviations below the mean in order to be eligible for Part C early intervention services. So that would be a score below 77.5 and a standard score. You can also see in the third column that we have subscale scores and that those are reported for expressive and receptive language as well as gross and fine motor skills. In the subscales, the mean is 10 and the standard deviation is 3, and therefore eligibility for services would be determined if the score is below 5.5, which is 1.5 standard deviations below the mean. So in our patient's case, we can see that adaptive behavior score is 80, cognitive score is 97, the total language score is 102, but that really doesn't help us very much because it doesn't break down the difference, if there is one, between expressive and receptive skills. So the subscale scores are a better depiction of where a child really is with their language development. And if we look at those, we can see that they're both solidly in the average range with an expressive score of 11 and a receptive score of 10. Similarly, the standard score on motor development doesn't really help us to separate out whether the score that's a little more than one standard deviation below the mean is related to delays in all areas of motor development or in gross motor or just in fine motor. But the subscale scores do help us to sort this out. And so again, with the mean of 10, we can see that the gross motor score is 6, the fine motor score is 9. So the fine motor skills are within the normal range, but the gross motor skills are just between 1 and 1.5 standard deviations below the mean. The social emotional development score is 95, which is solidly in the average range. While the adaptive behavior score of 80 is again between 1 and 1.5 standard deviations below the mean, that's likely affected by the delay in gross motor skills, especially when cognitive and language skills are in the normal range. Now, technically, this child does not meet the criteria for early intervention services based on these scores. There can be times when the early intervention team can override the scores, say with clinical judgment that they've determined that the child has a need, and offer services because the concerns about gross motor development are also having an impact on adaptive behavior. At the same time, we might find that the child was found to be ineligible for early intervention services, but we may feel that some sort of intervention would be helpful, and a referral to physical therapy services in the medical arena might be of value. And as we talked about earlier, as we put that into place, we want to track that child's progress carefully and reevaluate them in a few months. Now let's take a look at our second case. This is a 24-month-old who presents for a preventive care visit. As recommended, the Ages and Stages questionnaire was completed prior to the visit. You can see that there are concerns raised in communication, but other areas of development are within the normal range. There are no concerns about the child's hearing, but there are definitely concerns about understanding and use of language. There's no family history of hearing impairment. In addition to the ASQ, the MCHAT-R was completed. The score of 2 shows no concerns for an autism spectrum disorder. The history indicates that this child has 20 words at 24 months of age. He seems to understand well, but gets frustrated when people don't understand him. He has nice imitation and pretend play. He has excellent social interaction and eye contact. He's not had any prior vision or hearing evaluation. He's had no regression in his development, and he does stare unresponsively for 30 to 60 seconds twice a week. I might be thinking about whether or not this might indicate that he's having seizures, but this kind of episode would be highly unlikely to represent seizure activity, including absence seizures, which tend to be in children a bit older and with a much higher frequency than what's been described here. You may have noticed in the ASQ that the parent had noted some problems with sleep and with constipation. We're not going to focus on those for the purpose of this particular review. This is a real case, and these were real concerns that the family had. It may be more important to note that this was an unwanted pregnancy with a birth at 32 weeks gestation. Birth weight was 1,675 grams. The child was hospitalized for 4 weeks to feed and grow, but fortunately did not have any neurologic complications. He was abandoned by his mother at 18 months of age with his 2.5-year-old sister and 2-month-old brother. And he's now cared for by a maternal grandmother and her boyfriend who moved from out of state for a new job. They have no social support system in the new community, and they're not aware of early intervention, and they're leery of seeking government-supported services. This child's general physical examination, neurologic exam, and growth were all normal. You were able to allay some of the family's anxiety about working with government services and were able to effectively describe what early intervention is and what would happen if an early intervention referral was made. And the family agreed to accept that referral. In this particular case, the early intervention team performed the Battelle Developmental Inventory. And again, we have the same setup that we had with the Bailey Scales of Infant Development. One great thing about these two different developmental assessment tools, which are commonly used by the early intervention system, is their scoring systems are exactly the same. So with the standard score, the mean is 100 and the standard deviation is 15. And with subscale scores, the mean is 10 and the standard deviation is 3. Again, in Ohio, you have to have a delay of at least 1.5 standard deviations below the mean in order to be eligible for direct early intervention services. In this particular case, you can see that the adaptive behavior score is 82, cognitive 97. The total language score is 80, which is between 1 and 1.5 standard deviations below the mean. However, you can see that the subscale scores provide us with additional insight. The expressive language score of 5 is greater than 1.5 standard deviations below the mean, but the receptive score of 9 is in the normal range. Children with expressive language delays have a much better prognosis than children that have both expressive and receptive scores that are low. Receptive language delays tend to indicate the potential coexistence of an underlying cognitive concern. You can see in this particular case, the cognitive score of 97 is solidly in the average range, which correlates nicely with the receptive language score. However, there are definite concerns about expressive language. We can also see here that the motor score of 102 is in the normal range, and that this child has a relative strength in gross motor skills, but both gross and fine motor skills are in the average range. The social emotional score of 85 is 1 standard deviation below the mean. So we can see that the social emotional and adaptive behavior scores are both somewhat below average, but likely to be affected by the expressive language delays. And we know that this child gets frustrated with the fact that people don't understand him, and this could certainly have an impact on his social, emotional, and adaptive functioning. So overall, this would suggest to us that this is a child that has an isolated expressive language disorder who would benefit from early intervention services, but beyond having an audiologic evaluation would not need any additional medical workup and would not need to be referred to a specialist for evaluation. Let's move on to our third and final case of a 30-month-old who's a new patient who presents for a preventive visit. Since this is the 30-month visit, the ASQ was administered. You can see that there are definite concerns in the areas of communication, fine motor, and problem solving, and that he also falls in the gray zone on gross motor and personal social development. The family feels that he hears well, but has concerns about both expressive and receptive language, about gross motor skills, and note that he has some additional medical problems that we need to understand further. There's no family history of hearing impairment, and there are no concerns about his vision. As I mentioned, this is a new patient. Spanish is the family's first language, and the visit was assisted by an interpreter. The history revealed that he sat at 8 months, crawled at 14 months, cruised at 20 months, and walked independently at 27 months. He said his first words at 24 months and now has about 50 words. He's not yet using 2 words together. And he's not using utensils. It's important to keep in mind that there's fairly good data that would suggest that parents can be accurate in describing what their child is doing now, but they're much less accurate in being able to recall when a child achieved certain developmental milestones. So I tend to rely much more on what is the child doing now as opposed to when did the child hit a certain milestone. At the same time, I want to be sure that there's not any history that would suggest that there's regression in development, nor that the child has reached a plateau and has not been making progress even if it's slow. Now, this pregnancy was complicated by gestational diabetes. A cesarean section was done for failure to progress, He weighed 3,940 grams and was 52 centimeters long. There were no postnatal complications. He has 5 siblings without developmental concerns, and there's no family history of a neurodevelopmental diagnosis. However, there are some notable findings on his physical examination. His length is at the 8th percentile, weight's at the 69th percentile, and head circumference is at the 75th percentile. He's alert and playful and easily engaged and makes good eye contact. He has 8 cafe au lait spots, a large 7 by 6 centimeter one in the left axilla, one that's 3 by 4 centimeters on his back, and the remaining are 1.5 by 1 centimeter. There's no axillary freckles and no palpable neurofibromas. No Lisch nodules were seen in the eye exam. He also had a grade 2/6 harsh systolic ejection murmur near the left upper and left mid-sternal border, which radiates toward the right upper sternal border. He had a regular rate and rhythm and equal pulses. There were no focal findings on his musculoskeletal or neurological exam. Now, this child's picture is clearly clinically consistent with a diagnosis of neurofibromatosis. However, let's say that the physical exam was completely negative. Then we'd have an opportunity to really take a look at the algorithm that was published in Pediatrics in September 2014 that guides us in how we might evaluate a child with global developmental delay. The results of the ASQ and our own observations and history would support that this child is demonstrating significant delays across a number of domains of development, and therefore a more intensive evaluation and recommendation would be made if the clinical diagnosis did not confirm an etiology. So in this case, the diagnosis is neurofibromatosis, and we'll go over the results of his testing in just a moment. But I just want to remind you that the American Academy of Pediatrics would recommend in a child without a clear-cut underlying etiology based on the history and physical to have genetic testing, including a microarray and DNA for Fragile X. More and more, the question is being raised about whether whole exome or whole genome sequencing would be appropriate in these types of cases. The cost of those keeps coming down, and this may be updated at some time in the future. Second level testing includes a series of metabolic tests, including blood and urine, and you can see those outlined here. This would be the kind of case where there may be value in seeking out consultation. However, the initial testing could indeed be done in the primary care setting. Given the significant physical findings, the following testing was completed for the child. An MRI of the brain was normal. An echocardiogram showed valvular pulmonic stenosis that was mild in degree. And neurofibromatosis type 1 sequencing was completed. And this identified a previously undescribed variation in the NF1 gene that was not present in either parent, indicating that it was likely the explanation for his overall picture. Neither of his parents had clinical findings consistent with neurofibromatosis, and therefore his picture indicates a spontaneous mutation, which occurs in about 50% of the cases, while the other significant portion would usually be autosomal dominant. An eye exam did not show any concerns either. So this child does have a genetic finding consistent with neurofibromatosis type 1. If the exam was completely normal in the presence of the delays that we've observed, obtaining a microarray and DNA for Fragile X would be indicated. Additional metabolic testing would be warranted if those two were normal. Now, this child had a somewhat different developmental evaluation using the Mullen scales of early learning. This is a popular tool that's frequently used by child psychologists to evaluate children's overall development in early childhood. Its domains are gross motor, visual reception, fine motor, and expressive and receptive language. The visual reception is really a measure of nonverbal cognitive problem-solving skills. You can see that the scoring system is different here. It uses T-scores, But keep in mind that you're probably familiar with T-scores because you probably have used an instrument like the Conners behavior rating scales, which reports T-scores. In those, it's important for us to remember that the mean is 50 and the standard deviation is 10. With the Conners scores, the higher the concern, the higher the score. So generally, T-scores that are greater than 2 standard deviations above the mean are of significant concern. Some might say 1.5 standard deviations above the mean. In this particular case, the lower the score, the more the concern is. So the mean is 50, the standard deviation is 10. In this particular case, the child's gross motor score is 35, visual reception is 30, fine motor is 27, expressive language 25, and receptive language 28. So you can see that the language scores and fine motor scores are greater than 2 standard deviations below the mean. The visual reception or cognitive measure is really at 2 standard deviations below the mean. And he has a relative strength in gross motor skills, although those are still significantly delayed at 1.5 standard deviations below the mean. This is clearly a child who does have global developmental delay. Now, if you look at these scores, you actually can't truly differentiate between whether this is a child who may turn out to have an intellectual disability or a child who could possibly fall within the autism spectrum. So in cases like this, where there's significant delays across all domains of development, consultation with a specialist may indeed be warranted. So we've reviewed 3 different cases: a child with isolated gross motor delay, a child with isolated expressive language delay, and a child with global developmental delay who turned out to have neurofibromatosis. The first 2 children could easily be managed within the primary care setting in collaboration with your colleagues in early intervention. The third case may indeed benefit from additional evaluation with a specialist. Now let's turn to some of the other issues that may help us to successfully link families with early intervention services. This study by Jimenez, published in 2012, looked at barriers to evaluation for early intervention services. They interviewed 22 families that were evaluated by EI, 22 who were not, and 14 EI employees. The parents reported communication problems with their pediatrician, including misinterpreting reassurance and not understanding the referral process, and we've addressed that issue in our cases. Many parents saw themselves as experts on their child's development and felt they should decide whether their child pursues early intervention services. We have to respect that decision, but hopefully we would also work on developing a strong therapeutic relationship and a close follow-up plan that would allow us to monitor that child's development very closely and hopefully get the family to a place where they would accept a referral. Some families definitely preferred to wait for the developmental concern to resolve, or they wanted to work with their child on their own before seeking EI services. Again, a close relationship and a close plan for follow-up would be important in those kinds of cases. For ambivalent parents, practical obstacles, especially limited completion of evaluation, but highly motivated parents overcame those obstacles. Early intervention employees felt that families avoid evaluation because they mistake early intervention for child protective services. This is another example why it's so important for us to explain exactly what early intervention is and what's actually going to happen when we make a referral to early intervention. Based on what we've learned so far, there are a number of strategies that we might consider to help us to be more successful in completing the linkage to early intervention once an abnormal screen has been completed. First off, we can recognize the parent as an expert on their child and see them as a partner in this process. We have to acknowledge the parent preferences when discussing developmental problems and support giving developmental concerns time to resolve or to work with their child on their own before seeking services, as long as they agree to close follow-up. We can offer developmental activities that they can work on if they're somewhat hesitant to pursue early intervention, The Ages and Stages manual has some wonderful, simple activities that families can do to help to work directly with their child right away. I'll often use those activity sheets and give them the ones that match where the child is developmentally, and then several sheets after that, as opposed to giving them the ones that are just at the child's chronological age. It's important for us to avoid over-reliance on reassurance because it minimizes the concern and may lead to hesitation for seeking further evaluation and services. And we want to highlight the benefits of pursuing evaluation and the benefits of early intervention. And as we've discussed already, we need to be able to describe what's going to happen when we make that referral. We also need to be tuned into the fact that health literacy might have an impact on the ability of the family to follow through on our recommendations. This particular tool that's outlined here is called the Next Vital Sign, and it's a quick measure of health literacy. You can see that what is done is that even with the medical assistant at the time of check-in, the family might be given this food label, which happens to be for ice cream, and then asked to answer 6 questions that would give us an idea of the level of health literacy that the family would have. If they get greater than 4 of the 6 questions correct, then they would be determined to have adequate literacy. If they have less than 4, there's a possibility that they have limited literacy. And if they have less than 2, there's a greater than 50% chance of marginal or inadequate literacy. And it's important for us to keep in mind that education level does not predict health literacy. This is a tool that was first published in the Annals of Family Medicine in 2005. It's available in English as well as Spanish, and I would encourage you to explore it, especially if you serve a population where you have concerns about significant degrees of health literacy problems within your practice setting. Now, if we think back to our 3 cases, one of the cases was a family that had limited social support and was somewhat suspicious of seeking out public services. Another was a family of Spanish origin who had some significant language barriers. It's important for us to think about principles that will support these families in successfully taking advantage of our healthcare delivery system. One guiding principle that I often think about is that each family has their own culture, and that we shouldn't assume certain cultural beliefs simply based on a name or the color of someone's skin. In fact, if we really want to understand a family's culture, perhaps the best way for us to do that is to ask them to talk a bit about their family's values and beliefs, and especially as it relates to their beliefs as it refers to children with developmental disabilities. So we want to communicate by attitude and behavior and openness to different cultures. We want to be willing to adapt our clinical practice to acknowledge patients and families and caregivers' culture. We want to demonstrate a commitment to professional development that's aimed at acquiring new cultural competence, knowledge, and skills. We should consider that often the variability within cultures, even between affluent and poor African Americans, may be more pronounced than between cultures. Again, every family has their own culture. For example, poor inner city African Americans and poor whites from Appalachia may face more similar socioeconomic barriers and challenges than those faced by wealthy African Americans. There's also significant variability between recent immigrants and those that have been in the United States for 1 or more generations. Cultural assimilation, to include acquisition of English language skills, often increases with time spent in the United States. The Academy of Pediatrics has a toolkit called the Culturally Effective Care Toolkit, and it gives us tips for working effectively with interpreters. This was certainly important in our 3rd case in order to be able to get accurate information and be able to strengthen the relationship with the family. Some of the tips that the Academy suggests are to give the interpreter a quick summary of or an introduction to the patient and briefly share what's anticipated and what will be covered during the visit. Even though the tendency is to establish eye contact with the interpreter, it's very important for us to maintain eye contact with the parent or the patient. We want to speak slowly, use simple and easy to understand words and phrases. We want to avoid jargon. We want to avoid interrupting the interpreter once the session is started. And we want to invite the interpreter to share specific cultural practices or challenges that might arise during the encounter. While we're required to provide interpreter services, there are different types of interpretive services available, and there are pros and cons related to them. The cost that's associated with interpretive services is cited as a significant challenge in providing linguistically appropriate services to diverse patient population. Language lines charged by the minute might be the most expensive alternative. The positives about this kind of an approach is that there's a large cadre of multilingual interpreters, and it can be effective if it's very brief encounter or it's a very uncommon language. The con is that it takes away the physical presence and visual contact that one can definitely benefit from having. Trained independent interpreters usually charge by the hour and would be more cost effective if several patients needed interpretive services during a given block of time. So trying to bring your several patients together on the same morning who speak the same language could help to make that more cost effective. There are definitely newer video conferencing and mobile computer technology methods available in some settings, offering promising options, but they're not yet widely available in office-based practices, but are becoming more and more common. The on-site interpreter's physical presence is often favored by providers and can be instrumental in assessing the patient's nonverbal language and visual cues as well. A few other tips for your busy practice. It can be very helpful to have a diverse clinical, nursing, and administrative staff that's reflective of the local patient population. And these folks can potentially serve as cultural brokers. It would be important to become familiar with local community-based organizations that can serve as a valuable resource for specific areas of need, such as interpretive services. You might want to consider adding a few key questions to the medical history questionnaire, including has the patient or parent consulted a traditional healer or used medicines or herbs that the pediatrician did not prescribe? And what does the patient or parent believe is the cause of the illness? Might consider group visits of monolingual or limited English proficient parents, families, and patients as an option to minimize interpreter-associated expenses. And we need to anticipate and allow for extra time that might be necessary with interpreter-assisted patient encounters. I hope that you found this time that you've taken to review this module to be helpful. I'd like to just wrap up by suggesting some changes that you might want to make in your practice, and we'll tie those into our original learning objectives. The first objective was consider the role that culture and language have on families' perspectives of development. You might want to consider screening for health literacy in your practice and looking to recruit a culturally diverse office staff. The second objective was to identify culturally sensitive strategies to support families who do not seek treatment in a timely fashion. One strategy that you might consider would be to ask families to share their beliefs regarding delayed development. And then our third objective was to devise solutions to help families navigate the process from the pediatrician's office to community agencies. And the two changes that you may wish to make in your practice would be to make the referral to early intervention directly from your office and to be able to describe what happens when a referral is made. So think about making one of these 5 changes in your practice and how you might implement that in a quality improvement approach. Start small and make rapid changes and see how things go. I wish you all the best and thank you for your time. If you'd like to get more information on this subject, here's several references that you might want to look at. in more detail.